respond and discuss points that they think are salient and of interest, and then we'll ask you, the audience, to give us any feedback that you like. Then we'll move into the next part of the case. There are 3 parts to this. It's one continuous story. We've just broken it up into different segments. Do you need a copy? No. We have the Smiths, who have been married for over 55 years. Do you need a copy?
I do, I'm Sharon. Oh. We're good. We're colleagues.
Yeah, you're Susan.
I'm just Susan, yeah.
The Smiths have been married for over 55 years and referred to a private duty home care agency to provide services for him. The couple lives in a home with adequate resources to meet their needs. Their daughter and her family live on property adjacent to theirs, and they visit routinely. Both are alert and oriented, have full decision-making capacity. 24-hour care is initiated with a combination of private caregivers and agency services to oversee Mr. Smith's needs. You can see in the printout the different medical issues attributed to both Mr. and Mrs. Smith. We find that 6 months later, Mrs. Smith has a fall and breaks her right humerus. Her blood alcohol level at the time of the fall was 0.18. Care is increased to include services for her to assist during her recovery. The family contacts her primary care physician and works him to their concerns over her continued alcohol use, but no action or intervention is taken. Any thoughts from our panel?
I guess the only thing, I think the only way you can look at family is to look at family. And I think it's interesting in this case that the focus of care is on the gentleman. But we know in real life when you're taking care of one, you're taking care of the whole family. Because all those family dynamics go into it. And I think that's one of the benefits of this case is it brings out all the family dynamics and the importance that we need to address those and that they need to address them head on. Because if you don't address the root right away, it will keep coming up. I'm a gardener, and if you don't get the weed at the root, it will come back, and it will come back voraciously. So I think the key point that I highlighted was, we have concerns over the continued alcohol use, but no intervention is taken. And actually, that's a huge action by taking no action that I think has huge consequences. And if you don't address it early on, it will only exponentially increase. And then it's more cost prohibitive to take care of. Where if you attack it now or address it now, you could maybe handle it in a more economically viable way with minimal consequences. Comment in the back.
I have found lately that some of my patients have been drinking alcohol because they have been in pain. And the pain has been so severe and has been overlooked that they try to overcome the pain with alcohol. And this guy has rheumatoid arthritis, so probably his pain is not well controlled. And probably the wife is pain? Okay. So anyhow, sometimes the people is on pain, any kind of pain, physical or psychological, and that's the reason they have been drinking.
Let's go with Judge next.
I was just going to say, responding to those comments, they did increase the care to provide for services. The fact situation indicates that the alcohol abuse problem and the histrionic behavior is of long standing. So although they've known it was there, either they've tried interventions in the past and they've not been successful in preventing reoccurrence of the behavior, or they've never tried it because she's so difficult and they've always just kind of worked around that some way or another. I think that information certainly needs to be conveyed, but they do have apparently appropriate care levels going on with these people. For whatever reason, Mr. and Mrs. have been able to live together for 55 years, such as it is. The daughter's there with her family. I guess that's thrown in to indicate that she is there to kind of oversee the whole thing and to keep it from getting in blazing flames before she can do something else about it. But, you know, wanting to let them kind of continue to get along the way they've been getting along. Hard issue, but I don't think that after, I mean, assuming the lady's 75 to 80, I'm not sure you're going to stop some of that at this point, or not going to stop it right this minute with the price you're willing to pay. If she can still be at home after she heals from all of this, and you can sort of semi-monitor the alcohol abuse. The thing that's the most alarming to me is still drives. I probably would be looking at stuff like, you know, I don't know much about cars, but somehow getting that car disabled in a way that takes a very long time to get it fixed. Which is, you know, a common thing, you know, lost the keys, we can't get the locksmith to get us another one, that kind of stuff, so.
I would just reiterate what Judge Spencer said from a practical standpoint. There's no trigger points for intervention. They're safe, they're cared for, number one. We don't see any financial elements of abuse going on, number two. And then the final thing is what Judge Spencer mentioned, which is this has been going on a long time. The alcohol abuse is not new. So while it caused perhaps the fall, maybe, that's not even clear from the scenario, but we're not going to stop a long-standing abusive habit.
Or not without a really dramatic intervention that may be more disruption to their lives than what everyone's willing to do, because a lot of people are willing to live with a lot of that stuff.
And just one, we'll go to you next. One last thought on this is, it's been funny in all the years of social service I've been in, we'll have a team get involved with a family situation like this, and inevitably somebody says to the social worker, you need to go fix them. You need to go make her stop drinking. Okay, I wish I had the magic bullet, but like you're saying, this is a long-standing pattern in this family, and that's the way that they relate to life, and that can't be changed in your 80s. Question?
Emails every night, and this is my in-laws before they died. I mean, it comes 4 o'clock. It's got to be 5 o'clock somewhere, and they start drinking the bourbon and the scotch. I mean, that's their culture, and they didn't grow up with don't drink and drive. They didn't grow up with those admonishments, and so it's a whole different.
It's a lifestyle.
atmosphere.
Absolutely.
But we are, as a physician, we are obligated to ask the patient anytime to quit smoking and quit drinking alcohol. So no matter the age.
Yeah, I guess that's the comment I would reference. Yes, I know it's a family pattern. I know there's, you know, the things intact. And I know people typically don't change a lot over their lives. They may change in incremental degrees. But I do think we do have an ethical responsibility as healthcare providers when we see an activity that can potentiate bad consequences, that we do have the responsibility to take some action, either bring in awareness, offer resources, and sometimes bring the elephant, recognize the elephant in the room, and just acknowledge it. Because by saying that, we could offer a support system to the daughter. We could offer options for things to be done. I think that we do have the ethical, professional responsibility to address it. They have the autonomy to say thank you, no. And we have seen that time and time again. But I have anecdotally witnessed people who have abused for 40 years stop. So I don't think that we should say they've done it for, I don't think we should discriminate because of their age and not offer them awareness and options.
Not to discount it entirely.
Yeah.
I'd like to comment on the driving too, because you all are in the position that none of us are in. You have the knowledge and the medical ability to make assessments. those of you who are social workers have the ability to make assessments and recommendations. And that driving issue is so important and so serious. The underinsured driver who gets hit and can deplete that person's entire estate and cause this house of cards to tumble because then they can't pay for the caregivers when that wreck happens and somebody's hurt and the money goes to pay the accident bill. And I've had that happen in a case where, you know, it wasn't intentional. The lady pulled out of the driveway and somebody sideswiped her and neither had adequate insurance. It was my client's fault because she pulled out. She had $100,000. The back injury of the medical bills alone were $300,000. Oops, all the money's gone. So driving is not just a physical thing, it's a financial thing, it's also the other people. And I think the question that we'll often ask the family is, and you as physicians need to be saying this, and you as medical professionals need to be saying this, would I want to put my kids in the car with them? And if the answer is no, then they shouldn't be driving through the neighborhood back and forth to the grocery store.
The good news on that is that the state legislature just passed the new law where I believe that a senior, I believe the cutoff age is 75, it could be 80, but I'm not.
75.
75, where every 3 years they have to get their eyes tested. If she's beginning to have macular degeneration, she's probably going to end up having them not give her license anyway.
There's also been some cutting-edge research done at the University of Oklahoma, and I wish I could remember the woman's name. It's a physician in the med school up there, and it's really wonderful. I think you can go online and get it. So as physicians, you could look at that, and there are trigger points for when people should or shouldn't be driving. And then there's a wonderful ceremony that an East Coast attorney I know does, where he takes the key when the doctor's written a letter and says, you know, none of us want to do this, but we have to do this. And because they forget they can't get in the car and drive, and we've had people come into court and tell us about that, is to take the key and take it in the doorway and bend it by slamming the door on it. And then the older person has that physical reminder every time they go to get in the car that they can't drive.
There also is a program in the university hospital here locally that has a driver simulator that you can refer clients to. Medicare pays for it through physical therapy. Just need a prescription for that. They'll run it through the simulator and then they'll make a recommendation from that.
Also, the University of Alabama has a driver retraining program for seniors, for those who can still drive, who need to improve their skills. And they even have one for, and this is very interesting because of our conversation about competence and capacity, for low-level, cognitively impaired people who do very, very well with added training to improve.
Number one, as a health provider, you cannot, in your office, tell the patient that they are unable to drive. You can't do it. You need to get a driving evaluation. That you can do. Patient has to go for the driving evaluation. The only thing you are legally allowed to do is to document in your medical record that you have concerns over their driving. I don't even know for sure if we're allowed to send a letter to the...
Yes, there actually is a medical form that you send to the DPS that says this person should not be driving, and then the medical board will review that information and contact the driver.
There's one other thing that they will allow also. The Texas Department of Public Safety will go out to a house and will test a senior driver to drive just to the grocery store, just to the pharmacy, just to the physician's office, and will license them to do only that and drive only those places if indeed they pass the driver's test with the DPS officer sitting next to them.
What are the legal implications if you have a patient like this where you feel that their alcohol use has led to a safety issue within the family setting? Do you have any options as a healthcare provider where they must get care?
Well, let me respond to that a couple of ways. You all may be aware that in this community, finding voluntary or even involuntary treatment for a substance abuse problem alone is difficult, if not impossible. If you do find it, it's expensive, although I must say I recently had a conversation with an organization here in town that is providing substance abuse treatment, and their cost is $600 a day, which is $400 to $600 less than I thought that it was. But a number of years ago, when they told the state hospital they weren't going to be in the substance abuse business anymore, it shut down the care. And most of the substance abuse treatment that occurs in this community is done through the criminal justice system. So what are your options? Kind of limited. I certainly don't disagree that, and have seen in many medical records, you know, patient reports so many drinks per day, you know, told that they should quit drinking, quit smoking, need to lose weight. That's what most people are told. What can you do about that? Depends on how dramatic you think that problem is. You can attempt to mandate an inpatient substance abuse treatment option. Around here, that's not going to be just real successful right now. I think in this circumstance, you're better. I was just sitting here thinking, you know, if I were the daughter, I'd go around and seek out all of mom's hiding places and either throw that stuff away, which I think is a little later on here, or water it down. Just like disabling the car, you know, bending the key, where they may get frustrated, but they can't take the car. You know, if you water the alcohol down, if it's something that, this says wine, I believe.
Right.
It's a little harder to water the wine down. If it's white wine, you can water it down pretty easily. But I mean, you know, there's some things like that. Those are kind of sneaky, but, you know, hard times call for hard solutions sometimes.
Responsibilities. One is the social one. We had a case with a wealthy patient, macular degeneration, but he likes to drive. He has many accidents. He was impaired. So the best way that we sell the idea to quit driving is, if you get in an accident, the attorney will, once they find that you are mentally discapacitated, they will be happy to take all the money that you have done in your life. So still you can drive in your branch where relatively you are safe, but not doing on the street.
The only problem with this business, license to drive to your doctor and grocery store out there at Mentone, Texas, which is the county seat of Loving County out far west Texas. Population of the town is 37. The nearest doctor and the nearest grocery store is Pecos, Texas, 70 miles away. What do you do about that?
I'll break to that. Yeah, you get into the rural counties and it makes it challenging for resources.
Out of Amarillo to get a mobile van to go to those places. I mean, some of these counties have their population in the whole county is 10, and the average age is 86. So the only way that a lot of these people get any care at all is through the mobile van. I can see need to go to more places. We'll get them to go to more places.
Maybe Budweiser would be willing to.
It's a
All right,
good
we'll move
idea.
on just real quick. Blood alcohol level at the time of this fall is 0.24. While in rehab, she falls again, breaks her leg as well. 3 months following, she's provided minimal participation in the rehab. She's discharged back home with her spouse. Her cognitive status following her hospitalization has deteriorated significantly. She's frequently confused, disoriented, and expresses suicidal thoughts. During this recovery period, she has not had any tobacco or alcohol and has been monitored closely for detox concerns. Her PCP is changed to the facility medical director because her doctor does not visit the facility. During her stay at the rehab center, it's discovered that one of the caregivers that has been staying with the husband has access to the checkbook and the debit card. This is discovered by the family when they contacted the bank about the lack of receipt of the monthly statements over the past 3 months. There are several checks written and signed by this caregiver for amounts over $2,000 and drafts from the debit card in excess of $3,000. Ms. Smith is unable to assist in the investigation because of her own memory problems. When she finally does get home, the family is concerned about her focus on resuming her drinking and smoking. At home, there's a family meeting, and she is asked and agrees not to drive until cleared by the doctor, and the family has removed all alcohol and tobacco from the home. She is alert and oriented, but is frequently confused and forgetful, and now she's very angry at the loss of control. She often gets people and places confused. She's angry that there are always people around, that her family is doing her wrong. She does not want to participate in physical rehab because she says, "I hate exercise." Over the next few days, she backs the car out of the driveway, then later drives 100 yards to the mailbox, and according to the family, is beginning to exhibit drug-seeking behavior. They disable the cars and schedule an appointment with her PCP. Her family drafts a letter to the doctor requesting he address the alcohol and tobacco use, the driving issue, and refer her for a neurological workup to assess capacity. They deliver this letter to the doctor's office in person before her appointment. An agency nurse transports her to the doctor's appointment, but the client refuses to allow anyone to talk with the doctor before or after the appointment.
I just want to remind everybody, talk to your attorneys about the HIPAA aspect. There's a special exception that allows you to release information when it is in the patient's best interest. Stop hiding behind HIPAA. It's not there. What you all see as a wall is not there. I would like you to talk with your attorneys, make sure you're clear. Somebody had asked me on the break, and there's a government website, I'm sorry, I can't remember, it's been about 3 years, but it goes through all of the frequently asked questions about HIPAA when it was first implemented, and that question is specifically addressed in there, under what circumstances. And one of them would be a circumstance for a potential emergency, or there's potential harm to the client, and I think it goes into great detail about that.
Just another thing that occurs to me, the caregivers getting the checkbook and the debit card, that, as you know, is a pretty common thing to have happen. And one of the things that I did as a practicing attorney and discuss with people now is, you know, how you allow people to continue to have freedom and protect their assets. One of the things that, you know, stuff like the silver and the jewels and things like that, if you're going to have caregivers in the house, you really need to put that stuff away because it is not going to be there. And there are a variety of reasons why it's not going to be there. The checkbook and the debit card, you still want to have some freedom there, but move most of the money into some other account where that's not accessible to, you know, dad at home and the caregiver through dad accessing that, and just leave in that account money that you don't mind having stolen. Because that's probably, is it going to be stealing? I don't know. Obviously, a caregiver develops a relationship with a person, and much of the time it is a truly caring relationship, and they are the on-the-scene person providing some care for somebody who may not be real nice to care for. That doesn't seem to be real difficult in this scenario. But, you know, if the person being cared for might rightly feel a desire to make a gift to this person, that raises all kinds of ethical issues there. But it's, you know, they really do want to give them a birthday present. They really do want to give them a little money so that they can buy their kids something at Christmas time and stuff like that. So you have to really kind of weigh what it is you're willing to spend that way, how much freedom you're going to let dad have to continue to access bank accounts, you know, how much assets are there. If you have a private caregiver there and there's $5 million.
Extremely touchy and confusing for a lot of people because we have the issue of autonomy, and who are we as a child to tell our parent what they can and cannot do with their own money if they are fully cognitively unimpaired? It's none of our business, frankly. So I think that's an important issue as well. And another is with respect to something Dr. Ruzicka was talking about earlier, about, here we have someone who's alert and oriented but gets confused and forgetful, and I'm wondering about her meds, and I'm wondering if she's in pain, because pain alone can do that. So with that and the meds, who knows?
Well, in fact, if an older person is ill or has an infection, typically they don't spike a temp. Typically, they become confused. So that's a really good point. The one point that really strikes me in this conversation is where our energy is focused. I love how the case really represents Mr. Smith having a lot of physical chronic disease. And Mrs. Smith has other issues. But disease-wise, it's not as obvious, it's more subtle. But look where the energy is going in our conversation. And initially, the healthcare came on the scene to take care of Mr. Smith. But our conversation has been on Mrs. Smith the whole time. So
She's the one acting out.
But I want us to see holistically how much energy that consumes. And address the physical needs, which have been met, like you said, like we all have said, that the needs have been met. We're coming onto this case a year later, and so their needs were met. And now we're looking at where all the energy is still going. And I think the cognitive assessment needs to be done. I think an overview of the medications needs to be done. I think really I love how you mentioned looking at the source of the confusion, because a lot of delirium can be corrected. It could be a vitamin imbalance, it could be med interaction, it could be progressive disease. Alcohol abuse does correlate highly with cognition impairment. So there's a lot of things that need to be screened out. And I think the red flags are up on that. And I think the issue of ethics is paramount in the second section, because you're getting into that gray area of capacity. You're getting into the ethical issues of autonomy and beneficence, and are we doing good by what we're not saying? Are we doing good by not addressing some things? Would we do more harm by addressing things? And like you said, it is in context always. There's never a black and white issue on this, because it's live and it goes case by case. And that's where we as practitioners need to be well-grounded in our ethical decision making. And that's where we get into burnout, into mishaps, because we're not grounded ourselves in our core values and how our practice is ethically based. And there's a lot, like I personally use the Murphy ethical decision-making framework, and it grounds me. And so then when you deal with the families in context, individually, it opens up more options, and you have ownership. In this case, I love how the family has basically taken a lifestyle and given it to the doctors to fix. And they pointedly said that, fix my mother, who has had these issues for lifelong. So I think this brings in the multi-dimensional healthcare system needs to come into play here. We need to bring in all the other disciplines, the social worker, the psychotherapist, as well as the physician, as well as the nurse manager, to look at the situation and start offering some options and start opening up some doors on taking ownership here. And the family to really move forward at least needs the opportunity to be aware of the need to take ownership.
And I'm going to suggest a subtle way that you all can help with cognitive impairment clients and help families be informed without getting into perhaps what you're feeling in terms of, oh, I shouldn't interfere. There's several geriatric physicians here in town who have developed matrices in their offices, and they carry their laptops in. They complete the matrices during the exam, and at the end of the matrices, they have diagnosis, recommendations, and follow-up. And they quickly write a paragraph and another geriatric physician does the same thing and then dictates and has that sent out to the client afterwards. There's then a written medical recommendation that does two things. One, it gives the client the cues to follow up if their memory is getting minor, little blips. They've got the cues there. They're not saying, ooh, what that doctor say in that 2-minute visit, because I know I walk out of the doctor's office and I have no idea what's just been said to me. And that gives them something on paper that they can see. The other thing it does is the family member finds it lying around the house and then they know what needs to be done. I know oftentimes when you go to the doctor's office, they'll hand you a referral list and it says you need to go see the neurologist. Here's the recommended list that we have. Again, it's a physical thing that your staff can do without violating privacy as they're checking out in front of the caregiver from the agency, and you can make sure that the follow-up happens. So I don't like to hear physicians say, well, there's nothing I can do. I think there's a lot you can do. Just do it within the context of your practice, and it can really be beneficial to helping the family and the caregivers make sure that the ongoing care is given.
And actually, in this situation, when Ms. Smith returned home and we had the family meeting, the family did try to address the smoking, the drinking. They tried to address it saying the doctor's recommendation is that you don't do these things. They tried to address the driving. The client at this point says, you all don't like me, you're being mean to me, you're taking my rights away. I'm not listening to you. So the antagonistic relationship began in earnest, which is why the family then said, okay, maybe the doctor will believe. So that's part of the whole perspective of where we can go with this. What was really disappointing was the complete lack of follow-up or even response from the physician's office. And as the time that I've been doing this type of work, I've had several cases very much like this where we've taken to the doc. And I had one case where the doctor said, well, they've been my friends for 25 years. I can't tell her she can't drive.
Or drink.
Or drink,
I mean,
right.
10% of physicians are also alcoholic.
But I was just going to say, the problem is if the doctor had followed up on it, and is he not a mandated, or he or she not a mandated reporter, that the physician should have also reported this? I mean, you've got a blood alcohol here that's over your, I assume your state limits even in Texas.
Yes.
Even in Texas. Even in Texas. So consequently, should that not have been reported?
She wasn't driving.
Okay, she fell down when she had the blood alcohol, and the family has reported that it's driving. So putting A and B together, yeah, okay.
Yeah.
Second thing is, could they not have, and I guess I addressed the legal people in the panel about this, could they not have approached the bench regarding getting a guardianship at this point in time?
Many responses to that. It occurred to me during this conversation that it may be, daughter sounds like she's either the only one in that generation or certainly the only one on the scene. That's pretty clear. And I suspect that she may have a lifetime of trying to deal with this problem and have bumped into brick walls and been very frustrated about it. Just as an aside, it's not at all uncommon for us at the courthouse to receive information the treating physician refuses to fill out the information about, you know, Mrs. So-and-so, and of course we're going, okay, you know, if you don't want to provide that information, then you shouldn't be treating these people because your choices are to fill it out. At that point, you've gone from just being the treating physician to being sort of a fact witness on that. You could be on the other end of a subpoena to come to the courthouse and testify about what you know about, which is sort of our back pocket thing. Usually when that threat comes out, they manage to get a little more responsive on that. But I don't blame the doctor who's been not only the treating physician for 25 or 30 years, but the family friend for not wanting to kind of violate that whole relationship. If you do come to the courthouse, we can order different sorts of tests, and sometimes that gets sold to Mrs. Smith, for example, who's going, there's nothing wrong with me, it's all of you people, can be sold by, if you're right, Mrs. Smith, and this is exactly the way to prove that, that logic doesn't always hit home. But kind of a final thing that I think is important is, if you do that, let somebody else do, if you're the family and you're having this you know, aggressive relationship, let somebody else bring it down there so that they can be the bad guys and you can be the rescuing family member in an attempt to rescue what might remain of that relationship, because nobody is going to be more interested in the well-being of these two individuals, presumably, than the daughter who lives right there beside them all the time. And so she may be so frustrated that she can't do this and let other people, you know, different systems come in there and allow her to, you know, pat the hands and take over there, we'll try and do something about it kind of stuff. And maybe maintain some level of peace in doing it.
Any other thoughts, comments?
I have one that I wanted to speak to what you just said, which I think is really good, is to be aware of the caregiver fatigue already setting in. It's been a lifestyle that she's been embedded in, and we talked about this earlier, how when you're embedded in it, you don't see it. And she's trying to put Band-Aid upon Band-Aid upon Band-Aid, and she's fatiguing now. And so seeing that, our responsibility is hopefully bring in those resources for her to really look at the caregiver's needs. I think that's great. And that it is it's an immersion thing. And that we want to try to, it is very hard to get your arms around it in a non-defensive communication. And I think communication is so huge at this level. And like you mentioned, sometimes that's the biggest hindrance that you have is the lack of it. But the essential need for communication, but communication in not in defense, but more proactive. What are some options? And I love how you're trying to give the Mrs. Smith the ownership, because she's feeling loss of control. You know, what has always worked is no longer working. So the worst thing that you can do is come in and take more away without any autonomy, back to the ethical issues. So if we can really focus on communication that is not in defense, but is proactive, if we can focus on resourcing people where they're at, I think it ups the odds. So I really like your comments.
And what's pertinent to remember as well regarding the caregiver fatigue, yes, this is a lifelong pattern that this family is engaged in, and in addition to the declining health of her father, the cognitive deterioration of mom, now we've added to it this abuse financially of a caregiver, having to interface with the whole legal system on that end, and having adult protective services contact the family, having to work with the banks. It just really got out of hand fast. All right, we'll move into the last segment of this case. 2 months after this, Ms. Smith's behavior has continued to escalate. The family began providing her with limited amounts of alcohol as a panacea. Her drinking continued. She remained hostile toward those caring for her and her spouse. She's become verbally abusive to her husband, caregivers, and family. Her physician is of little support as he states that every time he sees her, he doesn't feel she lacks the ability to direct her care, and she refuses to see any other physician. She begins harassing her husband and frequently yells at him because he's hard of hearing, she claims, in a manner which agitates him, and at one point she even resorts to tapping repeatedly on the forehead to get his attention. One evening, after a particularly hostile episode, she drinks all the alcohol available, falls again, this time fracturing her hip, giving her a concussion. Hip surgery is ruled out. She's placed into a nursing home and provided with hospice care for pain and symptom management at the family's request. At this time, it appears that her pain is difficult to manage, and she cries out frequently and tries to get out of bed. She's developed pneumonia, has a complication following the fracture, HRSA at the wound site, and C. diff.
I want to hear what you have to say.
It's sad in that there wasn't more identification of the need to reach out while there was still the potential to react. And now it seems like her options are limited. It's a hard situation to manage a very angry, very active
typical, and actually, I'm just surprised that nothing happened a year ago when she was having suicidal thoughts, she was drinking to the point she was falling, she was clearly dangerous to herself, she was commutable and could have been evaluated at that time. Now, we can't force her into treatment, and she probably would have gone home and started drinking again. But one of the problems here is that the family is so codependent with her illness, she's obviously developing what looks like a dementia, maybe from her drinking, excessive drinking, maybe an underlying Alzheimer's process. She's having episodic delirium. I mean, this woman is clearly just going downhill, and nobody is just recognizing that she does not have the insight to say, I need help. She needed to have help against her will until she stabilized, so you can see what you're dealing with, because you don't know what you're dealing with in this case. So I think that she was committable a year ago, and she would have been committable easily before all this happened. Now, you know, she has methicillin-resistant staph, and she's not going to probably survive that. I mean, you know, this is a horrible outcome.
Well, the number one, you know, so that's a disadvantage. The MRSA, huge disadvantage. The fact that this has been a lifestyle, and that's the one thing that I think in dealing with families and in dealing with patients, I do ask with the patients, if they've made bad decisions, one of the first things I ask is, have they always made bad decisions? Because if they've always made bad decisions, then this is not a new behavior that we're going to fix overnight. It's not associated to delirium. It's not associated to anything else. And I think clearly this woman has a pattern of coping in a substance abuse manner. That's her coping mechanism. We're not going to change that overnight. And I think that's critical, because I think sometimes people think if people have made bad decisions, that when they age, all of a sudden that's something new. And no, they've been making bad decisions their whole life. And this is a scenario that comes from bad decisions. I think the issue that's really difficult is now this person is placed in, making more, sorry about that. She's placed in an institution with major complications. So the institution has the responsibility of addressing them. And where the community didn't. The family didn't. The private physician didn't. Other resources didn't. So all of a sudden now we are putting her in a long-term care institution, which typically has less resources, and is the people working with this individual have less education. So we have minimal resources, minimal education, and I think the hardest work I ever did really was as a nurse aide, because you don't have a monitor telling you what's going on. You don't have an attending that you can call, or a nurse 24/7 all the time. So your assessment skills have to be their best. I think the best clinicians are the ones that are needed in the skilled nursing facilities, because it's you and the patient having to assess. I think pain is a huge issue. I think that would be the priority in managing this woman at this point, and I would want to get in there, and it would have to be carefully done, because she has a history of substance abuse. So typically, to dose her adequately for pain relief, you're going to have to give a higher level than normal. She's at risk for hypoxia because she's got pneumonia. She probably has some immobility issues with the wound care. So managing her is going to be very tight. I mean, it will be an art form to manage her successfully at this point. And to hit the MRSA, you're going to have to give her some drugs that have some heavy renal implications, you know, and we already know with her alcohol abuse that her metabolism and her clearing isn't going to be as good from the liver and probably not from the kidney. So actually this case, very common, a very good geriatrician is going to have to manage her to get her out of this well.
And so these aren't patterns that you're going to break. And I know we have had a ward where we had 24-hour caregivers with the sole purpose of keeping her sober. You know, and then we had our best friend bring her a bottle of champagne. But, you know, those are the kinds of things these people just just get really, really creative, and it's very, very difficult to manage it on a practical sense. You know, they can have the legal tools, they can have the medical support, they can have the social worker support, they can have, you know, every support in the world, but when they've had bad behaviors, they're amazingly creative, and they have all day to sit around and think about how they're going to do it, and you have 10 minutes.
We'll go back here.
This is similar, is when do you get to the point where it's bad behavior, but then when do you get to the point where it's self-neglect, and then you're obligated to do something as a mandatory reporter, and then what do you do? I think that's, I guess I'm
Call
just...
APS.
I'd like to expound on what this lady just said, which is, what if, outside of self-neglect, what if it becomes neglect of her husband? Is it a domestic violence situation, or is it now an elder abuse situation and you're calling Adult Protective Services? So I have a question about it. Can someone clarify that?
Incompetent and you neglect, you get to do it. If you're incompetent and you neglect, you don't get to do it. So if you're seeing an incompetent, neglectful person, you have a mandatory reporting situation. If they're competent and they neglect, then it's a hard line. If they're competent and they're neglecting themselves, there is no reporting. But if they're competent, they're neglecting themselves, and you're sitting there with the spouse in the office, and it's pretty clear they're demented, and they can't communicate, then you probably have a mandatory reporting situation where the spouse who's incompetent, even if you're not their treating nurse, physician, or social worker, because that person isn't communicating well, and you've got enough professional insight to know that they're incompetent.
And just to respond, I would have expected to see this at the courthouse in the guardianship context, certainly sometime during stage 2 of this. I also think it would have been very appropriate to attempt to make a referral for a mental health evaluation to see if you could get a mental treatment. There's a bunch of, you know, the anger management and the self-medicating with alcohol kind of stuff. History of histrionic behavior, all of that would tell me that there was probably a lot of other stuff going on that never got treated, and she was probably bright enough and, you know, functioned well enough to not be treated for something else that was going on. That'd be my reaction to that. My clearly medical perspective.
You're a practicing physician or dentist, and you're a mandated person. Do you remain anonymous? How visible do you become? Because if you have cases that are obvious, and it's easy for me to understand how the doctor would be afraid to turn this in.
But, you know, my response would be, you can remain anonymous, which is what the law says. Sonia?
Any reporter to Adult Protective Services, regardless of who you are, you could be a neighbor, you could be a physician, a nursing home administrator, the judge, you would always remain anonymous. The only time the name of a reporter is ever divulged could possibly be in a court proceeding when the judge would order it. I've been doing this for 18 years with APS, 24 years total working with victims of elder abuse, that I've never seen that happen. So normally, you're always protected, you're immune. Not that a lawsuit couldn't be filed against you, but our law offers immunity to our reporters, and also to anyone who cooperates with our investigation.
But you can make the referral anonymously without revealing anything.
Yes.
But if you do that,
it hampers our investigation.
Right, it's much harder for them to follow through on the investigation, but they're not allowed to reveal to the person who made the referral. Okay. Although sometimes the fact situation is such that it could only come from one or two places.
And sometimes when our staff shows up after getting the case assigned, the clients or the family may become upset because it's not a pleasant thing to have Adult Protective Services around. It's no the Child Protective Services should have. And they will guess, we don't confirm anything like that. We try to redirect and let them know that we're here because you're in need of services, you're in need of help. We try to shift the focus to helping them and helping their family, rather than we're here to label them necessarily.
Sonia, could you give the website? There's an online recording available, and you can, if you go on the 1-800 number, if you hit Friday afternoon, you're going to be on hold for 4 hours. I kid you not. So, Sonia, if you'll give the website and the access, can you do that?
I don't have the website on the top of my head. It's on this handout.
Yeah, we have, that's it, right?
That is the website.
We actually did prepare a list of sort of helpful websites, which have the Adult Protective Services website.
If you click on report abuse and then you click on Adult Protective Services, it will take you to a website where you can choose that you're a professional. I recommend that you do that. There is a public website and a professional website. Not that we disregard the public, but when a doctor or a hospital staff or another professional is notifying us, it is going to get a little bit higher priority. So that does tend to go through a little quickly. If it's an emergency, we always recommend that you call the hotline or you call the local office. For San Antonio, it's 337-3168.
Very good. Any last burning comments, thoughts, questions? Thank you very much. I'd like to thank our panel for their
I just wanted to remind you all, please fill out your evaluations and your participant profile. We really need those. And we have boxes, or at least one big box, where you registered this morning. You can drop those in there. Thank you.
Have a safe trip home.